Amen. Okay, thank you very much, guys, for joining us for this forum. What we'll do, we'll start by just going around everyone present. If just introduce yourself, where you're from, and then move on. So hopefully people will not jump around my screen like they already do. So my apologies if I asked you 2 or 3 times to introduce yourself. Kerry, please let me know if you need a timeout at all. Thank you.
Thank you, I will do.
Right, thank you. So what we'll do, we'll start with you, Tanya.
Kia ora, called Tanya Mason Takawingawa. I'm the Regional Disability Advisor for the Ministry of Social Development.
Thank you. Marianne?
Marianne Hughes from Parent to Parent Southland, but also covering Otago at the moment as well. Thank you.
Dave?
Kia ora, I'm Dave Bainbridge-Zafra. I'm the General Manager of Facilities and Property for Southern.
Great, thank you, Dave. Kim?
Hi, I'm Kim Fleck with the Health and Disability Advocacy Service.
Thanks, Kim. Peter?
Hi, my name is Peter, and I'm from MySkill.
Thanks, Peter. Ruth? Good to see you.
Good to see you too, John. Kia ora koutou, everybody. Ruth Zynett, I'm the Primary Care Relationship Director at Well South PHO.
Thanks, Ruth. Catherine?
Kia ora koutou, Catherine Harkin, Consumer Liaison at Whatuara Southern.
Thank you. Margot?
Kia ora, Margot Reid. I'm a Community Advisor at the DCC and I manage the Disability Issues Advisory Group at Council.
Awesome, thanks, Margot. Hugh?
Tēnā koutou katoa, Hugh Lloyd Takawingawa. I'm the Director of Quality and Clinical Governance at Te Whatuora Southern, and I'm the Southern contact for consumer engagement and ensure that the Disability Working Group has everything that it needs. Kia ora.
Thank you, Hugh. I've just made a note of that. Everything we need. Thank you. Chris?
Kia ora. My name is Chris Ford. I am Regional Policy Advisor, well, actually Policy Advisor Southern Region for DPA New Zealand.
Thank you, Chris. Paula?
Paula Waiebe, I'm on the Community Health Council based in Dunedin, and I've got Dave here as well because he was having trouble linking in from his own link. So
I'm David Allen from Dunedin. Thank you very much.
Thank you, Paula and Dave. Sandy?
Kia ora, everyone. I'm Sandy, Team Leader Consumer Experience. So I manage the patient inquiries at Dunedin Hospital and the interpreting services. Thank you.
Thanks, Sandy. Marie?
Hi, I'm Marie from Youth Service, and I'm a youth coach, and I also work as a support worker for IDEA Services on the weekends.
Awesome, thank you. Hannah?
Kia ora, I'm Hannah, and I am a community facilitator at Your Way Kia Roha, as well as here in a personal capacity as an autistic person.
Awesome, thank you. Kerry, do you want to introduce yourself?
Kia ora, I'm Kerry. I'm interpreter today.
So rules, because we've got an interpreter, only one speaker at a time. Please remember to speak slowly, which I invariably forget, and suddenly Kerry or whoever's interpreting has to speak 100 miles an hour. So my apologies. So John Marable, I'm the chair of the Disability Working Group. So it's really good I have Hugh and Catherine to steer me to make sure that I'm doing everything that the working group is wanting us to follow on. And so it's really good working with everyone. We'll kick off. The very first item I've got is an apology from Philippa Henderson. Since our last forum, we were lucky to get Philippa to join the group. Philippa is based in Balclutha, and she was actually the Southern Regional President of People First, and she's also on the People First National Committee, which is the governing committee of People First. And also she sits on the Disability Advisory Group for the Donald Beasley's Violence Elimination Project. So it's really great that we've got her on board, but unfortunately she's had to put an apology in today. So it's interesting to sort of looking through what we've been up to in the last, since the last forum. And we missed the last quarterly one due to different reasons. So just going back through all the keynotes for the last 6 months, and it's a lot of the stuff that we've been working on has been in the background and been actually done by the IT guys, been working closely with the information systems in place. One of the biggest issues that was identified when the disability strategy was formed was the fact that we were arriving at the hospital and sometimes our needs were not being met, and sometimes it was just a lack of the information. Everyone has seen the health passport, which I haven't got one here, but it is literally A4 size. And one of the things that was identified, it was very cumbersome and was completely always having to be updated and things like that. So the IT team and Jack Devereaux looked at ways that this can be improved, and lots of things have been happening in the nationwide side. And now I'm just trying to look for the little acronym, which is the South Island Patients Information Care System, which is DIPEX, which is just, I understand, has gone live. And there's still lots of information still to be attached to it. So it's a work in progress. So that's really exciting. One of the other things that came out of the strategy, and again has been working on, is disability awareness training or disability responsive training for staff. The hospital board does have an online training for their staff, but it was just felt that there was something needed, something with more meat. And there was Julie Woods, that blind woman, had been running some courses which were well received. And then the hospital board approached the working group and said, can you guys come up with possibly a template that we can roll out and possibly roll it nationwide? So I did a presentation to the working group, and it was really good from the point of view of the feedback we got. And then we put that on hold because the national body is going to be running with that. So I just said we've got someone else join us, I think, have we, or just people moving around my screen? So yeah, it was a work in progress. Again, it's something that has been identified that it's an ongoing issue. Just last week we heard of someone who was having some issues with someone having trouble understanding them. So it's not just the staff needing to have training, but it's also that the consumer, for want of a better term, that we're aware of our rights, so that when we go to the hospital, that we are aware of our rights, what we can request and things like that. One of the biggest things is also that we're all different, so we can't all go there and want the same treatment. What we want is the treatment that we want. And it's sort of just making sure that everyone understands that. Okay. Something else that we've been working on is the concourse, but mainly it's to do with the council as well. All the work that's been going on in George Street outside the main entrance at Grand King Street, with all the work that's been going on with replacing the infrastructure, there's been a lot of disruption for parks and things like that. But now 99.9% of it has been fixed. The accessible car parks are in the same location. There's a flat access, so there's no curb to access. It's just a little ramp. There was an issue of the stop sign not being followed, so people were just about getting bowled over by vehicles. There is a lovely, nice yellow painted line there now. However, I was down there the other day and I see vehicles are still not stopping. A couple of bus stops outside the hospital there. There's issues with the design. They've got no manifestations on the glass, which means that they actually look like a clear line of path. So again, it's the working group has been in liaison with the ORC and the council just tidying things up. It was raised about the stormwater drains outside that entrance. With the new design, they're actually, the hole's very large. So Paul, I'm holding my hands up, just showing the height, size, and someone's crutch tip could easily go in there. I've been talking to the team at Isaac and they've informed me that they're going to be replaced. There's going to be a cover pot over them just to eliminate that risk. When it was first raised, we were told that it wasn't an issue because the accessible car parks were up further closer to the Hanover Street. I pointed out that no, it's nothing to do with the accessible park. You've got patients leaving the hospital who could quite easily get their walking stick, their crutch, their cane, whatever, caught. So it's good that the council, Isaacs, have listened to us. The concourse is going to be looked at. So there was the, when we talk about the concourse, sometimes we talk about the access from Great King Street to the concourse where the accessible parks are, where the entrances are. That's a work in progress, and the working group has been involved in some talks of how things can be improved. At the moment, if someone in a accessible car park uses the accessible parks, they actually have to walk behind all the vehicles to into the hospital from the concourse, which is not the correct standard. So there's lots of ways that can be improved and things like that. There's still ongoing, and it's something I'm being asked to look at, is accessibility up at Wakaree. It's just awareness. Unfortunately, the building code doesn't cover a lot of things to do with the spectrum. The Wakaree lift, for example, has got some really nice blue lights as you enter it. However, some people on the spectrum can find it very off-putting and they cannot enter the lift because of the lights, and then they can't access the stairs because it's secured lock. So little things like that, a little ongoing. But I'm more than happy to answer any questions if anyone's got anything about that. Okay, one of the biggest issues we've had as well is the lack of New Zealand Sign Language interpreters. And it's not just a Dunedin issue, it's actually a New Zealand wide. And I'm sure Kerry would agree with that. So it was very fortuitous. Catherine, William and myself, we were up in Christchurch at a meeting. So I rang up Lachlan Keaton, the president of Deaf Aotearoa, and said, hey, can you quickly pop down? We'll quickly share at lunch. And we had caught up with him, and then we had a follow-up meeting last month with him. I think it was last month, was it, Catherine? Time seems to be going so quick. And yeah, we're looking at ways that we can improve. The hospital board, and I think Sandy will agree, it's got a really good system in place to get interpreters. But it's just when someone arrives there very out of the blue, they've got emergency, they arrive at the hospital, it's just that sort of lack of knowledge. Who do we approach? How do we get someone? Things like that. And then it's also people who've got an appointment just trying to find, like, there's no interpreters in Invercargill. And so a lot of the stuff has to be done through iSign or one of the other interpreter services. And sometimes it's done via screen. So it's something that we're working on. We hopefully will be having another meeting with Lachlan and the different representatives of the ISIN, etc. Every meeting we go and have a bit of a round table around the members to find out what's going on, and issues at the moment with Oamaru trying to get into the emergency department. Sometimes central, it's trying to get even to hospital and things like that into appointments. People are still having issues with people in the blind community getting their letters by appointment, or they're arriving at the hospital and they are given a form to complete, and the only person with them may be the taxi driver or some person who's escorted them into the building. So again, that's a little bit to do with the training, but also just having something on our file, which is again something to do with the SIPEX, the South Island Patient Information Core System, having a flag so that we know what the consumer requires to ensure that the treatment they receive is as stress-free as possible. So that's really what we've been doing in the last 6 months. So more than happy to answer any questions. Hopefully I haven't missed anything, have I, Catherine?
The only other thing maybe is mentioning the Regional Health and Wellbeing Plan that we consulted on at the last meeting with Joy Christensen.
Oh, that's right. Sorry, my apologies for that. I will just find my notes. So this is a nationwide scheme. It's going out for consultation, and they're looking to get input from all communities, but especially from the deaf community and the disabled community. And they're just really looking at to ensure that the treatment we get is what we want. It's a nationwide repository of information, and it's really to look at upskilling the health workforce to increase their understanding. And one of the biggest things is to tackle the unconscious bias, and it's something that we all have. I know myself.
I've got some ramen noodles, but they're like the packet ones. Dinner potatoes for dinner tonight. I've got some pork belly, maybe we could stick some days mushrooms in there. I don't know if they just make a taste.
Hi there, Sheila. You've just corrected it. Thank you. The pork belly sounds very good, though. Thank you. The mute button is so good. The number of times I forget that it's on, or I forget to turn it off, and also just I will segue to Sunflower Lanyard. Maybe you can talk about that, Catherine, in a second. But yeah, so Joy Christian, she will be sending out more information about the Regional Health and Wellbeing Plan. It was good she spoke about it, and just there was aware that also the terminology and things like that. She was great that we had someone from the deaf community who spoke on language, and it was, again, making sure that the information is in a format that can be read by everyone. And one of the things is that it was going to be in New Zealand Sign Language, it was going to be easy read, it was going to be in a format that could be read by screen readers. The one thing we also spoke about was the Sunflower Lanyard. This was a international program that I understand started in the UK, and it's started being rolled around quite a few different industries, airports, sports centres, and it's a lanyard, or it's a card that people can hand to just let people know that they've got an invisible disability, and then they may need some additional support. It's really good. There's a lanyard, there's a card, there's a little badge you can wear, there's a t-shirt, there's a cap, there's so many different things you can get, and it's just, again, something that people need to be aware of, that if someone appears and has got a lanyard, this is what it's for. And it's something that we are looking at possibly in the southern region trialing. Any questions, guys?
I just want to say, as a lanyard user, like I'm wearing mine now, that it's an incredible tool, and I'm so proud that we are looking into being able to roll it out in the southern region. It's mostly been a great tool for travelling, but in terms of being able to walk into a hospital or doctors, it's just a great wee tool, even just for a receptionist to know that, you know, maybe I have some communication needs and that all you need to do is ask.
No, it's good to hear that. Thanks, Hannah. It's something that has been around for quite a number of years, and it just seems like everything to slowly make its way to the southern hemisphere. But every time, like Hannah said, the people who are wearing them, they just feel that they've just got a little bit more support, or the fact that they feel confident in asking, which is great. I think that's from putting my disability hat on. That's one of the hardest things, is asking for help. And it's no guarantee that you'll get that help, but at least, and that's the thing, it's the education. The more that people wear them, more aware of the Sunplough lanyard scheme and the program, the more it's going to be accepted.
Can you tell me where you can get them from? I have a lot of families or parents and carers asking me how they can access them, and I'm not sure where they can get them from.
Catherine, do you
Can
want
I answer that?
Yeah, thank
Or,
you. Oh, you can. Yeah, Hannah, you can.
Yeah, so you can, so any business that is a supporter of it can be a distributor, but you can also get them at the supporting airports. So, for example, that's Auckland, New Plymouth, Wellington, Dunedin is now one, and you can order them online. I think it costs for the full shebang. So I have the card as well for this whole setup. I think it was $17.50. And you can also get them at the House of Parliament, they're a supporter, as well as the Westfield malls.
Thanks, Hannah.
Thank you.
I think the more we push the more we talk about it, the more people are going to feel comfortable displaying that. Okay, guys, so the next item on the agenda is the Consumer Engagement Quality Service Marker, which I'll get Catherine to talk about. Thanks, Catherine.
Thanks, John. Just bear with me while I share my screen. Just checking that that's working okay.
That's good. We've got your screen up.
It is.
And on the left-hand side, though, we've got every page. So I didn't know if you wanted to do it. That's it. Looks perfect.
Is that better?
Yeah, perfect. Thank
Great.
you.
Okay, great, thanks. So I've got two things that I wanted to run through with you all today, and the second really leads on from the first. So the first is the Southern Consumer Engagement Quality Safety Marker. So we run this twice per year, in autumn and in spring. So I'm covering at the moment the spring 2023 results, and following on from that, I will also do my usual session where I talk about the feedback that we've received over the last quarter as well. So this is related to one of the key actions in the Disability Strategy Action Plan, which is that engagement with the disabled community will be assessed through the 6 monthly Health Quality and Safety Commission's Consumer Engagement Quality and Safety Marker. What is the Quality Safety Marker? So twice per year, we survey all services within Te Whatu Ora Southern, and we are assessing those services' consumer engagement against the Code of Expectations. So for those of you who aren't aware of that, just briefly, it is now a legally mandated Code of Expectations that dictates how health entities should engage with consumers. So this came into force in, I have been saying last year, but it's now almost 2 years ago in 2022. So it's about 18 months since this came into force. And however, this most recent quality safety marker is the first time we have actually been assessing services against that Code of Expectations. So the way it works is that we ask the service managers to conduct a self-assessment and to tell us about what is happening within their service for any type of consumer engagement, and that is then moderated by consumers, including the Community Health Council and the Disability Working Group Chair. So they help us to ensure that where, for example, a couple of services are doing similar work, that we are measuring them at the same level, so that what we are presenting to the Health Quality Safety Commission is a fair representation of the consumer engagement that we're doing. We have tailored this quite significantly to the southern region to ensure that we're asking questions that tell us what we want to know for our communities as well. So one of those questions in the most recent survey was specifically for this service, which population groups have been identified as having poorer health outcomes. Now, this is related to one of the key foci in the new framework, which is based on the Code of Expectations, and it is recognising that there are multiple population groups which do have a chance of a poorer health outcome, and that we need to be engaging more with those groups to redress those inequities. So for part of this, we were trying to find out whether the services actually knew for their service which population groups those were, because we know that it's not always the same population groups for every department within our organisation, and we wanted to see what the level of awareness was. So what we found was that the majority of responses included Māori and Pacifica. So there was quite a high awareness within most of the services that Māori and Pacifica consumers are at risk for a poor health outcome than some other population groups. Somewhat disappointingly, only 3 of our responses referred to disabled consumers. Now, the Code of Expectations actually highlights Māori, Pacifica and disabled consumers as being 3 key priority groups. So it showed that we've got a bit of work to go within some of our services to recognise that consumers who identify as having a disability are also at risk of a poorer health outcome. For Southern as well, where it was commonly identified that rurality was a key factor which could tend towards a poor health outcome as well. So we obviously have quite a diverse geographical region here, which is a blessing and also not so much sometimes. But the distance from a secondary healthcare facility can also impact the health outcome for our consumers as well. What was quite reassuring was that some services were really clearly able to articulate population groups for their services, which had been identified in their own data as having poorer health outcomes. Some examples of that were women's health, ophthalmology and respiratory. They were all able to quite clearly articulate what groups they'd identified as being at risk for poorer health outcomes. We also ask what is happening within your service to improve equitable access for the disabled community, including those with physical, sensory, intellectual, mental disabilities. So this question we have been asking, I think it's probably about the 3rd time that we have asked this question, and it's gone through a couple of iterations to just clarify what we were asking the services to tell us. In the most recent survey, we included the last part where we outlined types of disabilities that services might want to think about as they answered this question, and that was in response to a lot of answers in the previous survey that were solely about physical access to the building or to the department. And we really wanted to broaden the thinking so that we weren't solely getting responses about physical access, but that the service managers were thinking about other types of access that could help to improve the equity of the service that they're providing to the disabled community. So we had responses, quite a large number of responses to this, but I wanted to outline a few of them for you. So the New Dunedin Hospital told us that as part of the New Dunedin Hospital facility design, input has been actively sought from members of the community with lived experience of disability, including physical, mental health, intellectual, neurodiversity, sensory, and carers supporting people living with disability. This feedback has been integrated into the design. Rheumatology told us that we have recently moved our outpatient clinics in Dunedin to an area with accessible parking. Our clinics are on the ground floor. Support persons are always welcomed and their attendance is encouraged. Raised chairs with arm supports are provided in all waiting areas and clinic rooms. Radiology told us that they were working on the timing of patient appointments and being able to get them directly in without having to wait in the waiting area for patients with sensory or intellectual disabilities. And Women's Health told us that we have special protocols in place for our special needs patients. Although the space is not specifically designed, we have adaptive equipment and make every effort to provide the best possible service. It all hinges on us being aware in advance of the patients, though, as it is quite difficult to provide adequate service ad hoc. The other side of the coin, now some of these responses weren't quite so positive, unfortunately, but they are a realistic representation of the other side of where some of our services are. So one service told us that they weren't doing any more than any other group to provide equitable access. Another service told us that we find it challenging to discharge patients who need support packages from more than one service. For example, a patient with mental health or intellectual impairment who then has a stroke or similar and requires assistance for their physical disability. We try to bring all agencies together, but this is not an easy process to organise what is best for the patient. Another response outlined that this area needs work and that they would like this patient group to have a needs survey when they're coming to the hospital. And another service told us that we are reviewing a service delivery for our disabled community and at this stage are not aware of any barriers. So I think that's probably quite telling in itself if they're not aware of the barriers, because I think we probably all know that they're there. And part of the work here is going to be education to help them understand what those barriers might be for their service. So with the quality safety marker, we assess consumer engagement across several different elements. And there's a 4-point scale for all of these elements that we're assessing. The highest level is what we call partnership, and that's the ultimate goal. That's what we're trying to get to. But it's quite clear right across the country that none of the districts or the former DHB areas are at the level of partnership yet, and for all of us it is a work in progress, and I like to call it a journey because I think it shows that we are continuing along a progressive path towards the level of partnership. In terms of feedback, there's a couple of ways that we would look to say that we are at a partnership level for what we're doing with our feedback. And what I'm talking about with feedback is our formal feedback systems. So we will receive our complaints, our compliments, and our suggestions. So the aim here for partnership would be where metrics and systems are in place, they're well established and they're regularly reviewed, and that as a result, actionable changes are made with the guidance of consumers and staff, and that metrics are regularly shared with relevant stakeholder groups in an accessible way, and that feedback given leads to demonstrable change as appropriate. So part of what we're doing here, and the reason why I bring this to you every quarter, is to be transparent about the feedback that we are receiving from our disabled community, and to show you what we are doing or what we're working on as a direct response to that feedback. Now, the first one I have is a compliment, and it was actually quite nice to read, because this is the first one that I read when I was going through the data in preparation for this presentation. So this one was a compliment for the care received in the mental health unit in Southland. So the consumer commented on the gratitude for the friendliness and professionalism that it received in this unit, and that the whole team had been extremely careful, caring and attentive to that consumer. We also had a consumer and the support person tell us about an experience at one of our emergency departments. So this was an autistic consumer who presented with a support person. Now, the support person had explained on arrival to the department that this consumer was autistic, and that they could come across as blunt and potentially confrontational in some of their conversations. Now, I'm summarising here, but as the consultation went on, one of our staff members became frustrated with the consumer, and the complaint was around their communication with the autistic patient. So as a consequence of this, we did apologise to the consumer and their support person. The staff member involved has been spoken to, and they are looking at further training specifically for that person. So my next step here is to follow up with that staff member and their manager to see what training has happened there, and if there's a further way that we can assist with that as well. Now, at the last quarterly forum, we had quite an active discussion about the My Care Plan boards, and we have had another complaint come in the interim since that discussion, which I think shows that we have had progress since the initial complaint came in, but as I referenced before with the journey, that we're not all there yet. So this was a consumer who was under the care of a residential care provider and were admitted to one of our wards. So in this place, the My Care Plan board was used, but it wasn't completely filled in, and it wasn't entirely followed in regards to a few key areas around eating, drinking, communication, and physical capabilities. So I think we've got progress in that it is being filled in, but what we weren't quite at this point was the recognition by all staff who are engaging with consumers that they need to be watching that board and following it and understanding what the wording means in terms of their ability for eating, drinking, communication, so that it's actually being used effectively. So our response back to the residential care provider who put the complaint in was that further staff education around the use of the My Care Plan boards has been provided, and that this ward is conducting spot audits as well to check the use of these. So again, I'm keen to follow up with this ward and see how that's going for them as well. We had another complaint come in around the support of a consumer who had significant mental health challenges. So in this case, a consumer with significant mental health challenges had also suffered a physical injury, which then resulted in some fairly significant mobility challenges, and they were in one of our wards for a wee while. The complaint was centred around the fact that the consumer had been discharged without the appropriate supports in place. And so there had to be quite an extensive investigation as a consequence of this complaint. Now, what transpired was that the consumer had self-discharged quite early against medical advice. So in this instant, the plan had always been that there would be quite a comprehensive discharge process for this person, including ensuring that their supports were aware that there was appropriate follow-up in the community, and that this was all in place prior to the discharge. So when the consumer self-discharged early against their medical advice, now we had no ability to restrain that person from leaving. So our team was following up after the fact, essentially, to try and put things in place at quite last minute timing, unfortunately, which really wasn't ideal. So they had made contact with the support team. Unfortunately, the patient had self-harm in the interim and had been readmitted to another facility, which was disappointing. It really showed the value of being able to comprehensively plan for a discharge, and also referring, I think, to one of the comments from the quality safety marker as well, is that where discharges require input from a lot of teams, that is all able to happen so that our patients are safe when they are discharged from our care. And the final piece of feedback that we received this quarter was around a compliment for the care of a young child through a diagnosis process. So this compliment came in from the parent of a child who had been through 2 of our hospitals in a reasonably complex diagnostic process. And they expressed real gratitude for the fact that all the clinicians they worked with were extremely patient with recognising the needs of their child to feel comfortable and to settle themselves into every appointment, to ensure that they were actually able to get the best out of that child through the diagnostic process. And just a reminder as well about how to raise concerns related to accessibility or disability. We have a dedicated email address, disability@southerndhb.govt.nz. And if you are wanting to provide feedback, then that can be sent to feedback@southerndhb.govt.nz at any time. Just stop sharing so I can see you all again, and happy to take any questions.
Thank you, Catherine. I have a question with regards to the gentleman, well, I'm saying gentleman, I don't know if it was, the person who discharged themselves. What can be put in place there to stop them? Because, yeah.
Yeah, and that one was an extremely complicated case, I think, and our response to the support person showed that there had already been some quite extensive planning for what would need to be in place prior to the discharge. The reality is that if someone wants to discharge themselves from our care, assuming that they have mental capacity and that we have no need to try and restrain them, we aren't able to restrain them in that case. So I think in this case, it certainly sounded as though our team had done everything they possibly could at the 11th hour to ensure that there was supports in place for that consumer. And someone more knowledgeable in this space than me might be able to identify something else that could have been done. But it certainly seemed that there had been extensive planning that just wasn't able to be implemented because they self-discharged so early.
No, thanks for that. Just Hugh, over to you.
I can add just a general perspective on these types of situations. It's always a strange one to me when people decide to discharge themselves against medical advice, because it fundamentally that's just a breakdown in a relationship of understanding of the care plan. And then we seem to put this piece of paper in front of them which says, sign here, and then we don't have any responsibility, which seems to compound the whole damn issue. So clearly it's a breakdown in the patient clinician partnership, and I think it's kind of a strange thing in many ways that I don't quite understand. But having said that, clearly if the time frame for planning a complex discharge is very narrow, then the actual delivery of what the individual needs in that space will be pretty tricky. But I've always thought that discharge against medical advice was a complete breakdown of the aligning of patient-centered care in many ways, which is always disappointing.
Yeah, thank you. Tanya.
I had a couple of questions at the beginning, which I think have actually been answered, but I'll ask them anyway. One was, Catherine, you mentioned about the My Care Plan boards. I actually had to leave the meeting early last time, so I know that there was some discussion over whether information should be shared in a ward situation where others can read what could be considered personal information. What was the final outcome of that?
Yeah, I remember that conversation as well. And from recollection, where we ended up, I think there had been some concern that we were putting personal diagnosis information, etc., on the My Care Plan boards, and that wasn't the purpose of them. It was more information. I mean, in this case, for example, it was that the person couldn't eat solid food, I think, so that needed to be. So it was only visible in that person's individual cubicle, but it was more a safety matter, I think, that they needed assistance with that they needed a walking frame to be able to stand up. I think in the original case that we'd spoken about, the person was non-verbal, and so having that on the board, it was purely a statement that they were non-verbal and that they communication needed to be via a support person, or that they may be able to sort of nod or shake their head, and that was the extent of the communication. So we weren't trying to put personal diet or health information up there. It was more about physical needs and communication.
So is the patient asked for their consent to put anything up there?
I'm quite confident that they are. And if they didn't want something on that board, then we wouldn't have it there. Ultimately, the goal of the board is to make the experience for the patient a lot more streamlined. So my understanding is that most patients are happy for that type of information to go up there, but absolutely, if they did not want that information there, then we wouldn't use it.
I quite agree that I think most people would want information that's going to be useful for their care to be on the board, but I just wondered if there actually was a protocol around asking for consent to do that, and what would happen if they didn't give consent. But I guess that's an ongoing topic. So I'll move on. My other question was, the feedback that you've talked about has been put into has been integrated into the new hospital design. So does that mean that everything that you're getting in that feedback and that you're now putting in place in the old hospital will be in place in the new hospital?
Maybe misunderstanding your question here, or we may be conflating two different conversations. So the comment from the new hospital was that they had done extensive consultation with FIT, they called them FIT groups, which involved both staff and consumers, and there had been a lot of engagement with consumers from the disabled community to find out what they needed to be part of the new hospital. So that has been integrated into the hospital design.
Okay.
So I think that answers that part. And then if we're talking about things like, for example, the My Care Plan boards, Pure might actually know the answer to this, but my assumption is that we will have something similar, whether it's exactly the same or the same concept, I'm not sure. But I can't imagine that we would be losing those in the new hospital, but I'm happy to find out what the plan is.
Yeah, look, I'm not entirely sure about that point. You know, just on the My Care Plan board, you know, it is My Care Plan, which is the patient's. So I think it's a collaborative piece, and I think it is, you know, emphasising what Catherine has said. It's about the safety and the understanding, and a lot of it actually is around simple things about, you know, what needs to happen to me today, type of investigation. When am I going to go home? When's my plan estimated date of discharge? So that everyone is joined up with the patient journey, and then particularly about safety issues around potential food allergies and swallowing, etc. And I'd imagine we would absolutely need something very similar in the new Dunedin hospital build, and involve and have it clearly explicitly placed so that everyone is aware of the specific needs of that particular consumer.
Thank you.
Thank you for that, Hugh. Any other questions or comments? Okay, thank you very much, guys. I'll call the meeting, the forum, to a close. So thank you very much for your attendance and to listen what we've been up to. It's going to be a very exciting year, I think, with what's been happening with the hospital board and changes of positions, and the working group is meeting bi-monthly, but we are working during the off months, if that makes sense. So I'm looking forward to a really good year of reporting back at the next forum of what we've been doing. Thank you. So I'll finish with a closing karakia. Unahia, unahia, unahia ki te ua tapu nui. Kia watia, kia mama, te nangakui, te tanani te aia I te awa takitea. Kia ora, e wanga, whakiawia aka kia wanga. Kia tēnā, tēnā hui e tākie. Draw on, draw on the supreme sacredness, declare to free the heart, the body and the spirit of mankind. Wanga suspended high above us. Draw together. Amen. Thank you very much, guys. Enjoy the rest of your day. Please contact us if you've got any questions or suggestions or concerns. And looking forward to seeing you at the next forum. Thank you.
Thank
Thanks, guys.
you.
Thanks,
See ya.
Thank you.
Ka kite.